There's live.
There we go.
Now we're live.
Hey. All right, I think we're broadcasting. If you're watching, please comment to say hello so we know you can see us. We're going to give it a few minutes to get some folks, hi, Stephen, to let people get on here and see the stream. But while we're waiting, how have you guys been? Hey, Michelle. Chat with us. Let us know how you've been, how you're holding up, what you're doing to kind of get through self-quarantine, especially if it's something environmental. Or sciencey. We love science too.
Sciencey.
I have been really going all in on my garden. And I've been talking to Michelle a lot about that, bugging her. So, hey, Melissa and Larry, maybe if he's there. What have you been doing, Kelly, to keep busy during all this stuff?
Just telehealth, loans.
Yeah.
I sewed a lot of masks. I did enough masks for all my staff. I really don't have much spare time.
Yeah, you're sewing a lot.
Yeah.
Hey, Michelle. Hey, Tammy.
Cooking dinner. Stuff I don't usually do.
Michelle said she's quarantined in her garden and loving it. Same. I'm not. My garden's not quite as impressive as hers. She has about 50 raised beds, I think. But
oh wow,
I'm exaggerating slightly, but doing well. Working from home. Not really any change from my normal routine. Stephen says. And Larry says hi. Hi, Larry. Yeah, everybody's just a little exaggerating. Everybody's
Does it look like everybody?
And I'm excited. Yeah, this is a lot of our regulars, a couple new folks. Okay. What time is it? It's 6:02. Let me see.
Do you think there's, I don't know how many people you usually have. Do you think there's people trying to get on the blue jeans one instead of this one?
No, the other one wasn't posted. So I'm gonna give it a couple more minutes for folks to get on here. Hey guys, if you're just coming in, we're just giving everybody a couple minutes to log on and make sure the stream's working.
Oh, there you go.
Hey, Jenna's been playing in the garden. I've seen your pictures on Facebook. Oh, the snails have been awful in my garden too, Jenna. Yeah, I go out there to check on it and I just hear crunching. It's so gross.
Oh, gross.
Like, yeah, just underfoot.
We've been swimming. But Travis, Travis is home. He's used to jumping a lot, so we've been swimming.
You have a heated pool, right?
Yeah.
So that makes it a little, nicer.
We heated it up for this because there's only so much you can do. Yeah.
Oh, thanks, Dennis. My hair looks awesome, she said. I did it today. I actually styled it a little. It's been in a messy bun all week.
Yeah.
Or 3 weeks. Oh, cool. Melissa's working from home, and he's alternating weeks for urgent eye care. Thank you guys for continuing to work and helping people who need it. Hi, Clinton.
Wow.
I'm so excited. We got a lot of folks on here today. Yeah. So I am, let me share this post just in case in the event that we created. And then we'll get started so that anybody that's looking for it can find it. Let me see. It's not going to let me.
You guys, when I'm done, I can share my slides with you because there's some links in there to some articles and some videos that y'all might like.
Awesome.
As nerdy as you are.
Yes, this group will love that.
Yeah.
If you're just tuning in, we're just giving it a couple more minutes to let folks get logged on since this virtual thing's new for all of us. I'm just really excited that we found something that lets me bring in an extra person and share screens and, broadcast on Facebook Live.
Just do it all.
A challenge. I did a talk for YP today, and the program we used, Facebook made some change in the 2 hours since that one and the one before, and we scrambled, and Jasmine was awesome and found this software. So, yeah. We're trying it out.
We've been moving to telehealth, so we've been on it a week, and it's so congested at the site because there's so many people trying to be doing that now that we can't connect anymore. So I spent most of yesterday and today trying to get another site so that we can go to an alternative place when we have all the congestion we can't get in.
Yeah, Jenna says, hi, Kelly, do you work with Rebecca Fowler?
I used to work with Rebecca Fowler. Rebecca works at the hospital at Darnall now, and she. But I have talked to her and seen her in for a little bit. About a week ago? Yeah, or 2 weeks ago, maybe. Yeah, time's flying. I don't know.
I know. What is time?
That day and the other day. There's no actual week names right now.
I know we have a group chat.
We're not nerdy, except yes.
Yeah, except yes, we are. One suggestion is to hold meetings at the quarter hour. Yeah, these you talking about these live meetings, Stephen?
Oh, probably our telehealth, yeah.
Or oh yeah, your telehealth meetings.
Oh, telehealth, yeah.
Yeah, give people a little extra time.
Yeah, we just have to be willing to be very slow. You know, you can't stack up and you can't do things quickly. So
yeah, absolutely.
The therapists have been sending me stuff. They'll send me a screenshot of their telehealth meeting, and there'll be nothing but like feet in the air, you know, just the kids' feet, because they're like playing their feet up. They're like somebody else, their kid took them and showed them all their Barbies, you know.
There was a Jimmy Fallon video of his interview getting interrupted by his daughter running in and showing her tooth that she had lost. Like, yeah. we're all in this, you know, kind of doing this together. Okay, let me see if I can do this without sound. 2 weeks ago, maybe. Sorry. I want to make sure I get your bio right. Okay, I'm going to go ahead and get started. Oh, Microsoft Teams is currently free. Jonathan chimes in. Thank you, Jonathan.
Yeah, I think that's my problem is everything's free. We are using Microsoft Teams for our office staff, but all these telehealth platforms are free right now, and so everybody's just congested on them. I found one today that actually you have to pay some money for, but it's one I already pay for, so it's no extra money for me. And so I think maybe it will be less congested. That's my theory. We'll see.
Yeah, I think paying sometimes is worth it in these situations when things are.
Yeah, it's just one I already pay for because I use it for my LMN. Yeah.
Yeah. All right. Well, I'm going to go ahead and get us started. Thank you guys for logging in and being patient with us while we let others join us. I'm really excited that we were able to get this talk out on such short notice. I know we normally, of course, meet at Let's Eat Texas in downtown, and we're not able to do that this month, but I'm glad we are able to meet virtually and kind of see each other in this space. So I am Jennifer, for those who don't know. I think most of the folks on the feed are regulars or have been to at least one of the meetings, but I'm the one that started the group and runs it. So I'm excited to see some new names on there, and typically we meet the second Thursday of each month. Again, at Let's Eat Texas, downtown Killeen. I hope that some of you took advantage of their carry-out and take-home meals for tonight's dinner. I know I did. I'm excited to get that heated up. But we always, have a speaker that talks about something sciencey or environmentally. So I'm really excited that Kelly was willing to get on and talk to us about epidemiology. This is actually a topic I was wanting her to talk about anyways. And then COVID-19 happened and it was, even more timely. So I don't have our normal list of announcements. Usually I give out a sheet that has events and upcoming events, and obviously those aren't happening right now. But I will say, we're on Facebook here, and the podcast that I do, Sustainably Geeky, it's also on Facebook and Instagram. I just released a new episode on Monday, and it talks about my trip to Memphis with the Living Lands and Waters crew, and their alternative spring break, which was cut short by all of the stuff, but I managed to get in there the first and only week they had, so that was really exciting. If you're interested in that, take a listen. As we're going through the presentation, if you have questions, please post them in the chat. We will probably wait till the end unless Kelly happens to see something and wants to address it then. But since she is going to have a PowerPoint up, we'll try to, save the questions till the end. And I think that's everything. So I'm going to go ahead and introduce you, Kelly, and then we'll let you take over.
Okay.
Awesome. So this month, we are going to hear from Dr. Kelly Barr, Doctor of Physical Therapy, board certified pediatric specialist, and owner of KidZ TherapEZE. She also has a lot of letters after her name. I won't say them all, but they are all listed after her.
They don't mean anything to anybody but us.
But suffice it to say, she's a very smart woman and a personal friend of mine and her family. So I'm really glad that she's able to be on here. And so in addition to her day job running her pediatric physical therapy clinic, Dr. Barr has worked extensively with Rotary International's Polio Eradication initiative and is well-versed in disease control and public health. And so she's going to talk to us today about epidemiology and the current COVID-19 situation, including how it's progressed locally. And she's going to kind of expand on some of the reasons behind the different measures we've had to take and hopefully, what will happen if we follow those and can flatten the curve some. So Kelly, I'm going to let you take over now.
Okay. I'm going to kind of go back and forth sharing screens and coming out. So y'all bear with me because apparently in this format, the videos won't play. So I found another way to do them outside. So I'll kind of go back and forth. All right, application window, this one, share. Oh, that was close. All right, here we go. Good. All right. Can everybody hear me? Jennifer? Uh-oh.
Yes, I got you.
Okay, good. Okay,
yeah,
good. Yeah. It makes me nervous when there's no sound. All right. So, kind of start with some basics. This is probably all stuff that you people know, being that the audience is sciencey people. It is a virus. It originated in animals, likely bats. It's actually quite commonly found in bats, but this is kind of the first transfer outside the animal population. It attaches to the ACE2 inhibitors, ACE2 enzymes in the lungs, at those receptor sites. That just seems to be the perfect fit for that. And that's how it gets into the cells. 80% of the cases are mild to moderate. From the people that I've heard that are considered even moderate, they're pretty sick. They're complaining quite a lot about body aches and how sick they are. So don't kid yourself about what moderate is. It's like a really intense case of the flu. 20% are severe, and by severe they mean requiring hospitalization or ventilation. 1 to 3% are estimated, is the estimated case fatality rate. And you'll see this skewed in different places, probably because of unidentified mild cases, the disparity in numbers of tests that are done in different countries. So there's a lot of variability in that. It also depends a lot on health equity in different regions and countries. So you'll see differences in that case fatality rate vary pretty widely. And I think that makes a lot of people skeptical when we see numbers varying. I saw one of those questions in your feed of questions already. Fatality is higher in the elderly and in men. I thought that's interesting. We haven't really heard much about that until lately. The reproduction number has been one of those that's varied pretty significantly, but it's somewhere between 2 and 3. We've seen it as high as 5 and as low as 1. And everybody's questioned that disparity as well. So we'll talk a little bit about that. The challenge really for fighting this disease is its transmission potential is happening for a long period before you know you have it. So this is our information from Bell County. And today, and this is as of today, so 1 o'clock today, this was up. There were 84 cases. That's quite a jump from yesterday where it was 74. That doesn't mean we had 10 cases today, but some of the cases from days back finally made it on the register. So there's some that get reported delayed, and so you'll see the numbers jump like this because some of them hadn't made it through to the site to be reported. There's 3 deaths and 24 people have recovered. Yesterday it said 15. So 9 people recovered since yesterday, or again, it's just delayed and getting reported. So that means we have 57 people in Bell County infected right now that have been identified. You see our epidemic curve and all of this. This is from the Bell County Health site, so you can have access to this daily. And you see the age spread. I think a lot of people think, well, it's only really dangerous for old people, but there's young people dying of this as well. It is dangerous. It's not only dangerous for people who have high risk issues or elderly, it's also a problem for people who are quite healthy. This is the list, and I kind of did some markups on here to show you kind of what I see when I look at it. You know, of course, knew the first day, knew the second day, knew the second case, knew the next couple of cases, and then it was like, oh, and now we have community spread, so, I kind of look at this and I go, how fast are we doubling? So if you look now, we're doubling about every 5 to 6 days. The last time we the last doubling we had was from the 28th to the 3rd, and we haven't doubled since then yet. So we may have we may have another 3 or 4 days before we see that double again. But the doubling is because of that R naught factor that we'll talk about in a little bit. I'm going to go out from here and see if I can go back to you guys and go to a different shared screen here. Is that working, Jennifer? So this is the COVID-19.
Not seeing it yet.
Uh-oh. Okay, I got to go back. Sorry. I know what I did. Thank you. Okay, I got to go back to StreamYard.
Okay, technology.
Choose the application I want, which is, I don't want to do that one that's you because it's going to give me that tunnel effect, right? The Chrome tab, that's what I want. That one. Now I got it. Okay. Yep. Now you got it?
Awesome. Yep.
Okay, good. Okay. So I think a lot of people have seen this because I've had a lot of questions about it from my staff. And, everybody wants to know if we're going to close for peak week. And, that would be in a couple of days if you're going by the United States chart. But the United States is a really big place, and certainly we are not in the worst areas of this outbreak. We're in the lighter sections of the country. So, the peak week for New York is quite different from our peak week, but the United States in general says April 11th. And as we look at this, we're looking at all of these resources layered on top of each other. So if I look and I say, what do we have for beds? This is how many beds we're going to need at the peak. The shaded area tells us the least and the most. So it could be 42,000 all the way up to 201,000 beds that we'll need. If we look at ICU beds, it's the same thing. The peak of that is, estimated at a mid-range of 19,834, but it could be 9,000 to 42,000, okay? And then the same thing with the respirators. You can get that same thing at the peak. When we look at April 11th or so, April 15th, we're kind of looking at needing anywhere from 8,000 to 35,000 ventilators. That's not very precise when you look at that kind of a range. If I scroll on down and I look, this is all a concrete map that we have because that's time that's passed. But as we move into the predictions, and we look at that peak time of the 11th and 12th, the deaths per day could be 894 all the way up to 5,115. Okay. So it's, it's giving us an estimate as we go of what that's going to look like on any given day in the future. And that's based on us doing what we're doing right now. And of course, if that changes, then the graph changes. And we've seen that change a lot lately. This is the growing number of deaths all stacked on top instead of a per day death rate. So as you see it go, then you're accumulating deaths in the United States. If I come up to the top, I can change this to, I need to change it to Texas is what I need to do. So I'm going to go down to Texas. There. All right. And I'll go back up to our top resources list. So there's invasive ventilators that we would need. And so the max estimated need is about 1,456, but it could be as few as 208 based on projections. They don't really know. ICU beds, we're way below the number of ICU beds we have available. Ventilators, you can't even see the line of how many ventilators we have. We're so far away from it. Beds, it's the same thing. You see the top line tells me how many beds we've got and the max that we'll need. Okay, so resource-wise, with our current status of how we're behaving socially and our current transmission rates, those are the anticipated needs of our health system. And that's the reason we're doing this, okay? If I look at the deaths, a similar thing. If we stay on our current path, this is the estimated deaths. And it says, based on that, we're 15 days away from the peak in daily deaths. At the top, it says we're 13 days away from the peak need of our resources. So when people say peak week, it's like, which peak are you talking about? You got to be specific. All right. I'm going to go out of this and go back to, let's see, stop screen and back again. And I'm going to go back to my, hopefully it's still there. Back to my slideshow.
And Kelly, where were you accessing that information for the folks that want to look it up?
That one is, and I've got it in my slideshow as a link. And if you're in the slideshow, you can click the link. It just won't work in this particular Facebook Live thing. So okay. if you have my slideshow, you'll be able to click this link. But it's covid19.healthdata.org.
Okay.
Well, are you seeing that?
The presentation with everyone, just so that they kind of know where you're getting everything. So, okay.
Yeah, and I've got stuff in there that y'all probably want to delve into deeper, knowing how you are. So the R0, we talked about how that's varying, and that's caused people, anytime something varies or something's mushy as far as predictions, or the predictions are way off of what they originally were. I mean, the thing about this is it's all dynamic and it's unprecedented. So, and there's so many factors that go into every estimation. So if you take the situation in China and you try to make estimations in the United States, number one, we don't know if they're telling the truth. Number two, we don't know if they've given us all the data or some portion of it. But also, China is not the US. We think of them both as industrialized nations, but our systems and our social factors are not the same in both countries. So there's a lot of things that go into calculating this R0. And the reason it's so different is because social behavior and organization and contact rate all go into that. Let's just take Italy, for instance. Do they handshake in Italy? No, they kiss on both cheeks. So, if you want to spread some germs, we can take it up a notch from handshakes, right? if an infectious pathogen, has all these different constants that, just by the very nature of what it is and the duration that it's contagious and the infectiousness of it, the one thing that varies is the human to human interactions and the time and space that happens in. So when you look at population density and social organization and the seasons that it's embedded in and that sort of thing, all those things really vary that R naught factor, which is how many people you're going to share it with. So, when you look at the R naught, they'll say that's like 2 or 3. What that means is that if one person has it, they're going to share it with 2 people or 3 people. But we've seen that be 1 and we've seen it be 5. The estimation when we're shut down like this, like we are right now, is that we're keeping it under 1. And when we start to resume life, they're going to be monitoring that R naught to keep it under 1, because if it starts to grow, then it grows exponentially, which is what we've seen happen in other countries, and New York, everywhere. But one of the proof factors that this is true is we can look back at measles epidemics in the past, and there were 20 different R naught values for the measles in study periods in the past. So, we don't have a lot of data on COVID, so we've got to use data from other things to develop our hypotheses and figure out what our action plan is. So in general, just virus transmission, this is an envelope virus. It means it kind of has a case on it. It generally, they don't live well on porous surfaces like fabric and tissues. They tend to dry out. If they have an envelope, they tend to dry out. If they don't have an envelope, they'll live on stuff for quite a bit longer, several hours on a tissue or fabric. So this one's an envelope. So tissues, fabric, takes care of it pretty fast, 15 minutes. The half-life of the flu, which is also an envelope virus and rather similar to COVID in its nature and size, but there's the same testing is not available on COVID-19 in published articles yet. So the half-life of flu is about 1.5 hours on a surface. Now that's not all surfaces, they're not all equal, but on a surface that it really survives well on, the half-life is about 1.5 hours. So in an hour and a half, there's 50% less flu that is still, flu virus cells that are able to infect you. And then after 3 hours, then it's half of that. And then after 4.5 hours, then it's half of that. So it's continually decreasing in percent in viable cells. Okay. Usually by 3 hours, it's way less than 15% that you could get infected even off of stainless steel. Because we've all heard that quote of COVID's been cultured off of, stainless steel after 7 days or something. Yeah, that'd have to be like perfect circumstances, totally undisturbed somewhere. I mean, it just would have to be optimal circumstances, and those just don't occur very often. The transmission depends on a lot on the concentration of the virus in the droplets. So children are very good germ factories, and they stick their fingers in all their body's holes and share it with people. And that's really gross to talk about over dinner. But the more direct the nasal secretions are with the contact, then the higher the concentration of that viral load in those droplets. So, if you're in close proximity of somebody who's really, really sick with the virus, like a healthcare provider might be, then you're probably getting a higher concentration. If you're out and there's people who have less severe case and they're not coughing and they don't even know they've had it, that they have it yet, then the concentration of that, the viral load in those droplets is probably a lot less. The viral load in the droplets is one of the reasons why some of the testing isn't picking up. That's why, I don't know if y'all have heard that a bunch of the countries that bought tests from China and accepted those testing modules are trying to get their money back and are really upset because the tests are not sensitive enough to pick up a positive COVID unless they're actually all the way to the point of ventilator dependent. And so the tests aren't sensitive, and it matters that those tests be sensitive and specific. You need to know that it's not just a virus, but it's COVID, but you also need it to be sensitive enough to pick up before the person's coughing it on the entire universe and before they, in that early stage, you want it to be sensitive enough to pick up the early stage so they're not spreading it for 5 days before they know they have it. So the testing, being able to be sensitive to a lower concentration is really important. And that's what our labs in the United States have been really working to develop and are coming out with some great, much better testing than what was available before. One of the tests that's just came out, I don't know if y'all have watched the news, but Abbott has come out with a quick test that will work with the strep test machines that a lot of doctors' offices have. There's 18,000 machines in the United States, and they're typically in smaller offices so that the doctor can do their swab and then just do it quick and get a 15-minute test result on strep. So they're, asking everybody to pull out their machines and let's get them ready for COVID testing. But the sensitivity and specificity of those devices is much more sensitive than the tests that we've been using. And it gives us 15 minutes instead of, a lot of times people are waiting 4 days. My niece waited 4 days for her results because they had to be sent off to the capital of California or something. She's in California, and the dad of some kids she babysat came down with COVID. So she had been around them that day. She was negative. The envelope viruses like Corona will decrease to less than 15% infection positive after 30 minutes on most surfaces, even your skin. Now, undisturbed on the skin, if the droplet sits there on your hand and you never move your hand, never spread it around, it'll last a little longer. But most people will move and touch things and disturb it. And once it's disturbed, it really doesn't last very long, even on your skin. The problem is we touch our faces, like 1,000 times every 30 minutes, except when you're on Facebook Live, and then you don't. The viral load, the low temp, low humidity, and sunlight all increase, or low sunlight all increase the infection possibility. So the reverse of those decreases the infection possibility or the ability of that virus to survive long enough to be transmitted. When we look at hand washing, some of the interesting research that is out there about hand washing is that if you use alcohol or hand soap, both of those will take care of a virus. People are all the time saying, I couldn't get any hand sanitizer. I don't know if this is going to work. And, hand soap will do it. All right. You don't have to have something special, and you don't have to have a truckload of alcohol. I'm still trying to figure out what everybody is washing their hands with, since it's all sold out now, because I thought we all washed our hands before this. Alcohol residual on the hands can actually decrease your hand's ability to be hospitable to that virus for 4 hours after the alcohol's dry. So it just decreases the survival of the virus on your hands, dries out that envelope again and kills it, disrupts the envelope. So any disrupted droplets on your hand, meaning rubbing your hands or spreading around the virus on your hands, tends to even decrease the ability for it to infect. So sometimes you go places and you're like, man, they didn't have any soap in the bathroom. What do I do? Or, somebody stole we're having troubles with people stealing stuff. If you put a bottle of hand sanitizer out, it'll be gone. So we have all the wall mounted stuff. But people will take stuff, take a bottle of wipes, take whatever. They'll take whole pans full of wipes out of our cabinets. So, people are taking this stuff thinking that that's all necessary. But, if you're in a pinch, if you just get your hands under the water and rub a lot, you're probably going to disrupt it enough not to be able to infect anyway. And then you can wash when you get somewhere where you can. But even just rubbing and disrupting the virus on your hands decreases the transmission ability. The New York docs are saying, a lot of the anecdotal information about this is that The social isolation circle is the biggest transmission place. So families and social groups that continue to collect, whether it be church groups or prayer groups or, you know, some close family group that continue to get together, that's where they're seeing the most transmission, because those groups are closer together and they have a more prolonged exposure during that time. So, you know, they're seeing a lot more transmission in those groups than, say, going to the grocery store or, you know, not knowing. They're able to connect people into these groups quite a bit more than what we're hearing about, because HIPAA protects us from knowing any of that stuff. So the other thing is that, you know, if you wash more even at home, because, you know, you still have your family contact. So if you manage to get this somewhere and you're around your family, they're the ones you're most likely to transmit it to. So making sure you're cleaning your surfaces and washing your hands at home is good. It doesn't have to be alcohol, doesn't have to be bleach wipes. It can be soap. Soap is fine. Disrupting the surface again, you know, making sure you rub things, that's good. This is not a super bug like MRSA, so it doesn't, you know, a lot of people are thinking, oh, I have to have something really, really extraordinary to clean it, and it's not a super bug, it's a virus. It's pretty easy to kill. It's, you know, MRSA, super bug, you need special things to kill that. Viruses, all the normal stuff will kill it. It's just really bad if you get it, but it's not difficult to kill with cleansers. When it comes to gloves and masks, your skin is a really great barrier. My favorite tale since all this has happened is I was driving up to the grocery store to go and get some groceries from pickup, from the curbside thing. And as I'm driving across the front of the grocery store, there's a guy coming out and he had on a mask and he had it fitted really nice and he had on gloves and he was pushing his cart and it was full of Corona. So I didn't watch him to see what he did with his gloves or anything, but I thought, man, if I'd have had a camera ready, that would have been a great picture. But his gloves really aren't going to protect him more than your skin does. Now, if you have a lot of cuts or open sores on your hands, then maybe gloves would be advisable. But honestly, your gloves, people are disastrously bad at gloving up and taking care of their hands. So when you're wearing gloves, there's a certain way you need to put them on, take them off, so that you're not getting the infection back on your hands. And then you still have to wash your hands, so you might as well just use your hands and wash your hands afterwards. Your skin is a great barrier for viruses. The only thing that it does is it will catch it, and then you put it on your face. So masks, on the other hand, have a little bit different mode of protecting us in this particular world. So if you, again, if you wear a mask improperly, then you spread the virus. And, you know, the biggest thing is to make sure that mask is over your nose, your mouth, and wrapped under your chin and closed around all the edges as much as you can close it, so that you don't have big gaping holes, or you don't have it hanging so loose on your ears that it's not up against your face. Because the droplets can come in around the edges of the mask if you don't have it close fitting. And most people will just wear it super loose or hang it off the bottom of their chin and move it up and down at will. And now you're touching the mask, you might as well be touching your face. So, you know, think of the mask as a really contaminated, germy object, and you're going to now put it on your face. And that should be scary and it should be taken seriously. So when you're putting the mask on, you want to make sure that your hands are clean when you put it, and it's a clean mask, and you want to secure it over everything. Then when you're taking it off, you don't want to touch it again until you're taking it off. And then you don't want to touch the mask, and you don't want to pull it up and down on your face. You want to grab it on the straps and pull it straight off your ears if it's hooked on your ears, or if it's straps on the back, and you don't want to touch the whole front of the mask. And when you take it off, you can put it right in the wash and wash it if it's fabric, or you can throw it away right outside the grocery store in the garbage cans there. Don't throw it in the parking lot. That poor guy that's gathering the carts has to pick up all your germy stuff. And, you know, if it was too contaminated for you to deal with in your car, that little boy shouldn't be having to pick it up outside. Yeah, the other thing that I've seen is 1,000 people in the grocery store with their mask on and a cell phone. Leave your cell phone in the car. wash your cell phone every time you wash your hands, because you probably touched it that many times, and you put it on your face as well. So, think of the things that you put against your face and make sure they're clean. But don't take your cell phone in the grocery store. If you're trying to reduce the germ exposure, taking that in is taking in something that then is going to get germs on it that you're then going to put on your face, and you'll probably forget to wash it after you come out of the grocery store. So leave the cell phone in the car. Do masks work? There's a lot of controversy about that. There was a lot of people posting stuff about how you shouldn't use a mask. That's because so many people use it badly. All the things that I just talked about. So the one really great thing, no matter how flimsy a mask you have, is if you have a mask on, you're probably going to touch your face less. You might touch your mask, but you're probably not going to touch your face as much. If you're talking about a kid under 2, if you put a mask on them, they're going to touch their face 100 times more, chew on the mask, and all kinds of things. So I just probably wouldn't use a mask on a little kid. If you're worried about taking them to the doctor's office, I just put them in their car seat, cover them up with blankets, and the blanket will protect them from everybody coughing things on them there. Other than that, I just keep my kids at home and not take them with me. So let's see, I probably covered a lot of this stuff. Some of the stuff is, some of the stuff about how it protects you, and N90, everybody's, hoarding N95s or hoarding surgical masks or whatever. And there's a lot of controversy out there. I've read a lot of articles because, we can't get masks at our clinic for us to use. So I've read a lot of articles, how can I get that percentage up? So we're using fabric masks. We use a high density fabric that has, really tight weave in it. And then I use 2 layers. One's the tight knit one, one's a real tight woven one, and the other one is like a quilting cotton. And then we just add a tissue layer in between. And that way you can throw the tissue away that catches some of the stuff, and then just wash the mask, steam it with an iron, and you're back good to go again. And we can steam it even between patients with the iron, give it a nice solid steam, and then go back to work and not have to have, a new mask every time, and really decrease the germs on that. But think of the virus as being so tiny, it can pass through a screen. And so the virus is the net and the fabric's the screen. And the more, if you get a couple of layers of screen together, and they're 2 different sizes of screen holes, the numbers of wires in the screen is different in the 2, and then they're not exactly lined up. Now the gnat has troubles weaving through without bombarding or hitting something on the way through. And so the idea of bombardment as it's going through a filter that's too big means that it'll get caught because it bounces off some of the fibers and gets caught in the woven fabric. The tissue is non-woven, so it helps catch a little bit more and not have the holes in it. Now, research shows that there's still a good percentage of virus that can get through, but hopefully it's not projected as far. And so our social distancing can be a little closer. For instance, in our clinic, we're having to have our hands on the kids. We can't be 6 feet away and do what we do. And so this helps us with that, bringing the social distance closer, and then still not having to worry about the viral load reaching a point that could be very severe. So then you take it off, you wash it with soap and water, your virus is dead. Don't microwave masks, they catch on fire. Some of them have wires in them, which will catch on fire, but even a fabric mask with no wire in it will catch on fire. So if you haven't seen that on Facebook, that's fun. After somebody spent time making a mask and we're all out of fabric, having a picture of it in the, all burned up in the microwave was fun for me to see. So the next thing that I found really interesting is, the link is in the presentation that I'm going to share with you for the videos, but I'm going to share a video with you because I've been really watching drug development and because part of what we're doing here right now with our social distancing is we're trying not to overload the hospitals, but we're also laying low while they try to figure out something that will help us get over it, better ways to test so that we can identify and stay in better. And possibly even a vaccine. Now, we know vaccines take a lot longer to develop, but there's a lot of drugs out there that work at the function of the COVID virus. And, they've got a lot of research in vitro, but looking at it in a human body and how it acts is different from looking at it in the test tube. But we've seen all the chloroquine things, but this one's a new emerging one. And this guy is a physician in California. And this drug, the research already, it's already been done. It's already got the human trial stuff done because it's already been used with parasites. But it seems to function at the right place. So I'm going to share with you, and I have to go back out again. I'm going to share the video with you so I get to see your faces again for a minute. That'll be good. Uh-oh. Maybe I will, maybe I won't. There I am. Okay. Can you see me again?
I can see you. I don't see the stream yet.
Okay. I'm going to go to share the screen again. I feel like I'm talking and there's nobody there.
Hello.
No, I'm like, oh dear. Okay. So I'm going to go to this video and I'll have to move it around. I'm going to move it around 2 different times, and then I'm going to go back through and we'll look at the other parts. How are we doing on time? Do we need to go, or are y'all ready to keep going?
I think we're good.
Okay.
Everyone's been
going.
active. Yeah.
I'll keep going. Have you got questions already?
We've got a lot of questions piling up. There's several that will probably need to be done at the end, but I have a quick one related to what you just said. How do you clean your cell phone sufficiently?
Oh, alcohol. The thing is that it's an envelope, and so think of what alcohol does. It evaporates and dries, and it dries water out of things. So if you have water in your ear, you put alcohol in your ear, it dries the water out. If when we wash our hands with the alcohol, it evaporates really quick and dries out whatever's on your hands. So it's going to kill the virus by evaporating. So you can just use alcohol on your cell phone. I haven't had it bother mine at all. I don't use hand sanitizer that's got like aloe and stuff in it and leave weird gunk on your cell phone. I just use straight up alcohol. There's screen wipes. They generally are alcohol based too, but you're not going to hurt your cell phone with. I wouldn't dip it in it. I just wipe it. But that should be fine. Okay.
Bob says keep going. This is great information.
Okay, so as long as I'm not like boring y'all to tears, I'm kind of a nerd like you guys, so I get excited about weird things that I find. So, you won't hurt my feelings if you got to go. But if you have questions, I don't want to miss you being able to ask them. So I'm going to go to this video. I'm going to play just a few minutes of it. I could summarize it, but I think this guy does such a good job. I'm going to leave it with that, okay? Move it around a bit to get where, well, that was the wrong one. Can you see it now? Jennifer, do you see the YouTube video?
I see a chart. I don't see the video yet.
Okay, so I shared the wrong thing, so I have to go back again. Here, I have to go back to StreamYard. Okay, so I'm at stop screen, right? Now I share screen. I shared the wrong thing is what I did. Chrome tab, this one. That's the one I want. Now you got it?
Yes, I see it.
Okay, so I'll share the link with this later, but let me take you to the part that I think is very interesting. And I've seen this in a bunch of different formats. But I liked this, guys. It's kind of short and sweet, and then he gets into the drug, and I really like the idea of this drug.
So this is the cell.
Can you make it full screen, Kelly?
Yes, I think I can.
The bottom right, yeah.
Yeah, I just don't know if it's going to make it go away for you. Oh, that's weird.
The messenger cell for RNA to come out
Good.
the cytoplasm and allows it to be translated into protein. Well, the problem is that the virus, when it comes in, it also has its version of RNA. And of course, the ribosomes can't tell the difference. So they start to translate the messenger RNA from the virus into viral proteins. And these viral proteins can have problems. They can have unintended consequences. And these proteins can come in and go through these proteins that allow the viral proteins to go into the nucleus where they can cause problems. And that could lead to decreased immunity, especially against this virus. And some scientists believe that this is actually what's going on with the coronavirus. There's a specific target for this transporting in or importing in. And cleverly, they call this protein the important protein. And there are several different versions of this. There's an important alpha, and there's also an important beta 1. So otherwise, this is known as imp alpha and imp beta 1. And what ivermectin does is ivermectin shuts down this ability to transport in proteins, viral proteins in this case, into the nucleus, which diminishes the ability of the virus to cause harm to the cell. So this article that was published on the 3rd of April, 2020 goes into that data. And the version that I'm showing you here has a link in the description below, and it is a journal pre-proof of publication. And the summary of the article is, although several clinical trials are now underway to test possible therapies, the worldwide response to the COVID-19 outbreak has been largely limited to monitoring and containment. We report here that ivermectin, an FDA-approved antiparasitic previously shown to have broad-spectrum antiviral activity in vitro, is an inhibitor of the causative virus SARS-CoV-2 with a single addition to the Vero H-SLAM cells. Those are the type of cells that they use here in the test tube. 2 hours post-infection with SARS-CoV-2, able to affect a 5,000-fold reduction in viral RNA at 48 hours. That's a pretty short amount of time and a large amount. Ivermectin therefore warrants further investigation for possible benefits in humans. And this, of course, is weighty because this medication is already being used in humans and has been deemed to be safe enough to be used in humans. So after giving the cells ivermectin, they looked at day 0, 1, 2, and 3 to see what the relative viral load of RNA was in terms of percent. And you can see here over a couple of days, it drops 1, 2, 3, 4, 5 orders of magnitude in just a 48-hour period. So that's inside the cells, the amount of virus inside the cells. Supernatant is referring to the solution outside the cells. And here you can see over a couple of days, we have a 1, 2, 3, 4, almost 5 orders of magnitude drop in the amount of relative viral RNA. Here, they're looking at the RNA-dependent RNA polymerase gene, which we talked about a number of weeks ago, is the gene that's coded for by the RNA in the virus, and that is also known as replicase, which causes gene replication. Here we can see that ivermectin at specific concentrations completely knocks out that genome. And here we see the medication ivermectin inhibiting this IMP-A and IMP-beta 1 from allowing the coronavirus proteins from going into the nucleus. You see, when they go into the nucleus, the hypothesis is that there's an enhanced infection and reduced antiviral response. When ivermectin binds IMP-alpha and IMP-beta 1, it prevents it from binding to the coronavirus protein and importation through that nuclear membrane so that you have infection not enhanced, and there is a robust antiviral response that occurs. So this research is interesting because it does address the issue regarding immunity that we've discussed over the last couple of weeks. And it also correlates with what I've personally seen in the hospital, with patients arriving in the emergency room only to decompensate within the next 12 to 24 hours and die, which tells me for some of these cases that the only way you're going to be able to intervene is in those precious hours and days before decompensation. This mechanism that we're seeing here of reducing the immunity, reducing the ability to mount an immune response is an important one.
So that I thought that video was worth seeing. So that's, I think that's, let me double check my video and my slideshow and make sure, but I think I'm down to questions. Go back. Oh, that's here.
Humans.
Oh,
So
that's
after
funny. It's
giving
playing
the
through.
cells ivermectin, they looked at day 0.
That's funny because I couldn't get it to play a minute ago and now it's playing, Jennifer. That's fun.
Yay, technology.
I know. All right. So again, he talked about how this particular drug blocks the actual mechanism of the disease. And I think when we're looking at things, most of the things that we look at medication wise for things are kind of treating symptoms of this only. Or when we, if we have the flu, that's really all we kind of treat, other than if we can get the Tamiflu, right? But the rest of the time you're just treating with Tylenol, or all the symptoms are all you can work with, and just try to live with it till your body gets rid of it. But this particular thing, I thought it was interesting because it really attacks at the root of the problem. If you go back and you look at this video, remember the A1 is the inside the cell part, and the supernatant is the outside the cell part before it goes into that nucleus. So the gene replication and that sort of thing happens both inside and outside. And so that's stopping that replication from happening. Oh, this was the other thing I had in here. There's some great vaccine reports, and I've included this link for you if you want to go in and look at the vaccine prospectus and what kind of work they're doing on different vaccines. Some of the stuff that they're working on right now is just the quick easy thing is to give people who are what do we have, 25 people who are well right now, those people giving plasma to other people. The trick then is, when is the optimum time to share that plasma for it to actually have a benefit of preventing someone from getting COVID, and then will it prevent them from getting COVID? That's been used since the early 1900s. It was used in the polio era to prevent people who were particularly fragile to polio from getting it. The other vaccines that are coming, that are being researched, a lot of them are riding with a different type of vaccine. So it's kind of an add-on to, for instance, a TB vaccine that's already out. And I keep looking at the numbers in India, and I don't know if they're not reporting as much, or if India's in that warmer area, because India, I would think, would be really having, I think they'd be leading us on the charts, but they're not. And I'm wondering, they vaccinate for TB. So I have some questions about whether that has any effect on that transmission in that part of the country, because their population density is so much more than even New York that it's hard for me to imagine. But a lot of the vaccine research is kind of developing on top of and layering it with another vaccine that's already been tested. But most of that research is a good ways out. We're pretty fast at developing vaccines. If you ever get a chance, tour the Sabin Vaccine Institute down in Houston. It's really fascinating. It's a little bitty room with a lot of people in it, but it's a cool thing to see. But I don't see that being our solution. I think our real solution at this time is going to be for us to get this faster testing. Trying to get back to where I can see you, because I'm sure you can see me. I think the things that are going to stop us and let us go back outdoors are this faster testing and more testing, where more people can be tested and we can identify the people that have it and seclude them instead of all of us. And then, having earlier recognition. If you have to have such a viral load, then you're farther into the disease. So it's harder to, before you can even identify it. So you've already been spreading it for 5 days before you can figure out you have it. That's part of the problem. So if we can identify it earlier, that'll decrease transmission. And then if we can come up with some ways to treat it for the people who are so severe, then it won't be so bad to go out, and get it. So.
Yeah, my understanding is, since it's so new, it's really hard to know that window of the optimal test time from the time you get it to the time it's time for you to be admitted. What's the window to where you can be diagnosed and treated preventatively versus have to be put on a ventilator?
The average time in China, even at their peak, was like 6 days that people were showing up from infection time. So that's a long time to be running around hugging grandmas before you find out, that you have it. And I think, I think getting it down to where, and in my world where we work with nothing but medically fragile children, that'd kill off the whole population. So 6 days is way too long. So being able to identify it and have it sensitive at a lower viral load is important. And we certainly have achieved better than that, better than what China had as far as that goes. But, some of that stuff is still emerging and not available to us just yet. This particular drug is able to be administered at a time that seems to be apparently not too late. If somebody's crashing in the hospital ER, it's something they could give, and it decreases so exponentially the actual effects of the virus and the viral load that it should help turn people around relatively quickly in a couple of days. So it'll be interesting to see what that comes out like as compared to all the other new stuff we've seen about chloroquine and everything else.
Awesome. Well, was that the end of your presentation? Did you have anything else?
What other questions you got? Are they in the private?
Right. Yeah, we've got a few. So the first one that came up was Johns Hopkins is reporting upwards of 30,000 new confirmed diagnoses per day. CDC, however, is only reporting 12,000 max tests performed per day. So how does that work? The math doesn't quite line up.
The math doesn't add up. A lot of times the math doesn't add up, and I'm going to say that the United States is better at keeping statistics on healthcare than most, but it's still, even with all of modern technology, it still requires some doctor who's out there fighting for a mask to stop and input the data into something for it to get somewhere. And then it probably has to go through that hospital system. And then after it goes through that hospital system, then it'll finally get to the CDC. There's a tremendous time lag in these things. And you'll see that time lag even on the Bell County Health thing, because you'll see some of them that got reported April 3rd that actually happened the 27th of March. That's 6 days, and that's right here. That's in our own little tight world. When you start doing that across the whole US, you can just, grow that exponentially. But, a lot of the systems that are overwhelmed that we're looking for those reports to come from, for instance, New York, can you imagine them being worried about statistics? I mean, they're just trying to figure out where to put the bodies right now. They don't have time to, to make sure they send in their count. It's it's an issue, but you're going to see those lags. I don't know why one system seems to have a better count on it. Maybe they're the ones who are issuing out the tests. I don't know. I have no idea. I just know that it's that's not a new problem with COVID. There's time lags and a lot of stuff. A month from now, they'll all be accurate and the same. But if that's not helpful right now for us.
Yeah. Let's see. We had someone ask, are there two strains of the virus?
Yeah, I've seen that too. And I've been through an awful lot of reading about it and looking at it. And it's not two strains, like polio, there's 3 strains of the virus. Okay. There's definitely 3 strains. They're identifiable, but viruses in their very being have a tendency to mutate fairly quickly. And that's one of the reasons it's really hard to develop a vaccine, is because you're hitting a moving target with a vaccine. So going at the mechanism of replication is a very good strategy for fighting it, but it's not going to help with the immunity, like a vaccine. So the vaccine has to be broad enough for it to be effective for that. That's one of the reasons why, people say, oh, I don't get the flu vaccine because half the time it doesn't work. Well, we're trying to predict which flu is coming through. We have ideas of, but it's going to be a little different each year, and we're trying to guess at which one it's going to be. And sometimes it's hit or miss, and sometimes it's more miss than hit. So, it's not that the flu vaccine doesn't work. It's that it's a guessing game for the people providing it for which one we need to fight, They try to include enough to get the broad spectrum of it, but sometimes you miss it.
Yeah, it's tough. Like you said, you're hitting a moving target. Bob asks, what about seasonality? CDC seems uncertain. Do the predictions assume some sort of weather-related reduction in infection rate? And I'll add on to that. Do we think there will be a rebound in the fall or winter of this year? A lot of people are saying that it could come back after, it gets cooler again.
Yeah, there's some good articles on that on the Lancet. I could share some of those with you all if you'll like private message me, so that you can see those and see what that's saying. But it's not so much the seasonality that they're addressing. It's more right now they're still in the crisis of what happens when we lighten up and go back out the door. Trying to keep that R0 under 1 while we resume life. And how do we keep tabs on the R0 while we're resuming life? And because if you reverse, if you go out too much and the R0 goes too high and you start into that exponential spread, nipping back takes much more, like we would have to close down more than we're closed right now in order to reverse the climb in the R0. So some of the stuff they're looking at right now, because China's just now coming out their doors and they're seeing some reemergence, but some of the biggest things they're doing is just not letting people leave one city. They're not letting people come and go. They let them out in their communities, but not let them go from one community to another, not go from one city to another. But they're looking at what different social releases, when you relax a little bit, what social things have different impacts on that or not, and how much are we going to see a rebound, like you said, in the fall if we start to relax and go back outside. Then do we, there's still this many people that aren't infected, that aren't immune, that aren't, so they're still at risk. Now we had SARS-1. It came around before Travis was born. My son is 15. I don't know if any of y'all know Travis, but that was all happening about the time Travis was born. And they actually eradicated it by just contact tracing and putting everybody inside. And they used chloroquine with that, but it really wasn't the chloroquine that eradicated it. It was this other contact tracing. So getting to where you can identify a contact trace, other than everybody getting it, being able to really lock it up whenever we've identified it and not have it out there shared, is our other way of not having this be a seasonal thing that comes around infection rate. Why is the infection rate, less in the summer? Because we're outside and the sun kills the virus. So 15 minutes and it's gone out there. So, there's less transmission when we're outdoors, and, when we're indoors and we're all locked up what we are now, it's more transmittable.
Yeah, good point. Jackie asks, is there any validity to the reports that those who have recovered are still susceptible to catching the virus or developing complications again? Might be too early to...
I saw it. Yeah, I don't know. I saw an article about some people who had, quote, recovered in Korea, and then, it came back, and I couldn't find the research on it. All I had was like a little news story, and how, I don't want to say this in case one of you guys are the news, but how that can be. So when I don't see the research, if I read something on Facebook, it's like some little sensational news article or something. I'm always looking, where's the research? Where's the citing below? And then I go look for it in the Lancet or the PubMed or, one of the international journals on infection or whatever. And I couldn't find anything about those people. My big question mark is, how'd they determine they were recovered? Because when I hear recovered, what does that mean? Does that mean they tested negative twice? Which tests were they using? Were they using those Chinese tests? And now they're saying they're identified as having the virus. And really, they used a different test that actually was more sensitive and specific. And so they, if you're not using the same test, then maybe this test is more sensitive than that one that they had. Maybe they never tested them. They just thought, hey, they're walking around, they're doing good, they feel great, let them go. So they're recovered. I don't know. What I have seen is research that people who seemingly are recovered and think they're well still test positive for the virus for like 2 weeks. I mean, it really tends to hang on. And one of the things that the chloroquine came out with was that people tended to not test positive for as long after the point of of feeling well. So it was like 4 or 5 days instead of 2 weeks of testing positive after they seemed to be well. So, when I hear those kind of stories, those are the kind of things that are coming up in my brain. I don't have any facts on it, but there's where the question marks happen to me. I think some things I hear and I just get more questions instead of less.
Yeah, and it's still really early in this, so those standardized studies haven't all been completed. And also, like you said, when the variables change, that's something you look for in science, is you've got to be able to have a constant. And if several constants are changing, you can't have a baseline.
Yeah, it's really difficult. Yeah, medicine is really hard that way. The research on medicine, people, do you want to be the guy they test the medicine on where you're the one getting the placebo, dying in ICU? I mean, but guess what? That's what it takes, is that kind of research. And, it seems kind of unethical to give half of them no treatment in a research when you have something that potentially could help. That's really hard on a doctor to think about doing when they have a patient that's crashing, to go, gosh, I got to give them this, but I don't know if it's the placebo or the treatment. That's a hard thing.
While we're talking about on this topic, Tim asks, what about asymptomatic transmitters?
Yeah, that's the big hard thing right there. That's why being able to test people more, whether they're showing symptoms or not, is, and I still, again, I mean, being able to test more of the population is going to be what eradicates it, because then you would just test everybody, but we don't have that availability right now. But as far as the asymptomatic, I keep hearing this, but do you know of somebody who's actually been completely asymptomatic, or were they just not that severe? Like, oh, I had a little dry cough for a day. Was it, like I wasn't really sick. I didn't run a fever. I didn't do the whole package, but I had a tickle in my throat for a day.
Well,
I mean, does that count as asymptomatic? I don't know,
Yeah, and the problem is at least what I heard in Bell County is they're not testing you if you're asymptomatic. They're only testing people who have made it past every other marker, and you've called, you've done a telehealth visit, you have very severe symptoms, then you can go in for a test. Otherwise, they're just assuming you have it and you have to stay home and self-treat.
Right, yeah. And I don't know, all these asymptomatic reports, most of that has come out of China. I have seen some out of New Orleans, because one of the doctors, had written an article, and I can't cite it to you, but it was a New Orleans doctor who did a nice video, and, just about what her life was like in the ER, and wrote a rather extensive thing about the experiences she was having. And what she said was, she's treating a trauma case from a car accident, sends them in for x-rays to see what bones are broken, and they have the broken glass presentation in their lungs, so they test them for COVID and it's positive. Now, the assumption is that person was asymptomatic because they didn't go to the doctor and they were brought in because of trauma. But I don't know if somebody went back and said, hey, did you think you had the flu before you had the accident? I don't, the fact that they didn't go I don't know if that meant they were asymptomatic or just they weren't, they didn't come in going, I'm sick, and ask, did somebody say, hey, did you have flu symptoms? I don't know if anybody ever followed up with that. Again, I hear something and I got more questions. They also cited somebody who came in with a dislocated shoulder. They're doing x-rays of the shoulder, broken glass, x-rays on their lungs and tested them COVID positive. They said immediately afterwards, testing positive, they started checking. And the one thing, even though the people didn't have fevers, what they said was that their O2 sats were low. And I've consistently seen that in the literature. And the lady the lady doctor in New Orleans that was relaying this information said one of the things that she's seen rather consistent is O2 saturation drops in the clients coming in, even if they didn't think they had COVID. If she did the oxygen, that was more consistent than the fever. She said only about 45% of the people had fever, but a much larger percentage of them had decreased oxygen levels, even if they weren't coming in thinking that COVID was what they had, you know. 'Cause you can still go to the doctor with the flu and turn out to have COVID. I mean, and you could have the flu and COVID, I guess, you know, but yeah, you don't want that.
That's a rough life. Right there.
Rough, but
And
yeah,
allergies
I mean,
and
yeah.
you know, whatever else.
And you know, the flu's still flying around, you know, Colleen, there's still people getting the flu right now. So, you know,
yeah.
And it's funny, they test you for the flu, and if it's positive, then it's like, oh, well, you don't have COVID, you have the flu, but you know, you could conceivably have both.
You can have both. Yeah, I don't even want to think about that.
Yeah, I know.
couple more questions. And thank you for being on and answering all these questions everyone has. Everyone's really interested. A lot of thank yous and a lot of gratitude in here. And if you guys have any more questions, we are getting close to the end, so be sure to post those so we can get to them. Jenneth asks, isn't ivermectin what we use for heartworm treatment in doggos?
Probably is.
I don't know.
It is a parasite treatment that's used in humans too.
Yeah.
I don't know if it's used in dogs because I don't live in that world. It might be. I don't know. Yeah.
Yeah, that's interesting. Other applications, I guess.
Yeah, I mean, it is an anti-parasite medication, and you know, it works at that replication stage. So yeah, it just happens to do both. Yeah, but it has been used in humans and safely used in humans. So.
Okay. Just kind of making sure I'm going through, didn't miss anything. Larry says research got released that shows that it binds to hemoglobin, and he shared an article about that.
So go to the same guy that I did the video of, and he explains why that is highly unlikely. It's a theory, and it's a theory that's out there, but he explains what he's seeing in California, and he kind of discredits that theory, but he understands it and he buys into it. But when he gets to the very end, he's like, but the patients aren't presenting with both poor blood gases, and because he said with the hemoglobin, you would have poor blood gases, but not poor SpO2, you know, in your finger when you do your oxygen in your finger. And he's seeing that the SpO2 is low in all of his patients. And he said that there should be a disparity between the two if it was a hemoglobin problem, if it was a heme problem. Okay. I also thought that when they did blood testing that they would see all the busted up heme because it leaves residual parts in the specimens. And I only know that because they thought my mother had a disease that just like in 24 hours kills all your hemoglobin and you die when all her organs shut down, and they were testing her for that because she had busted up hemoglobin and her platelets were like 12. And so, you know, that hemoglobin theory was very much a theory, but I think when you see this guy's video, he explains it rather clearly. And I thought, okay, that makes more sense. I watched the one that Larry watched, and I thought, that's interesting. I wonder if it's true. But again, I had all these questions about, but wouldn't they have seen it in this way, and wouldn't they have seen it in that way? And this guy comes back and says, yeah, they would have.
Okay. Well, yeah, there's a lot of conversation going on about the ivermectin. Someone says they used them on their guinea pigs. Larry says they give them as shot to horses. So apparently it's a very versatile drug, and
widely used. And probably, you know, if it's available in the vet world and the human world, we probably have truckloads of it somewhere, you know. Mm-hmm. So you know, a lot of the laying low is waiting for the testing to beef up enough so we have enough tests, you know, staying healthy while the hospitals get prepared for the load that's going to hit them, and, you know, all these things. So, and getting the medicine supply up. So if we find a medicine that is relatively plentiful in our supplies already, that would be amazing, right?
Right. Yeah. Something that you wouldn't even suspect,
Yeah.
guinea pig or dog medicine, you know?
Yeah.
Well,
I'll tell you what, I'd take almost anything when I have pneumonia, because I've had pneumonia 15 months ago, and if they told me it was dog medicine, but it would cure me in 2 days, I'd do it in a minute.
Yeah.
There's nothing worse than trying to get air, you know? Yeah.
Yeah. Definitely. I'm not seeing any more questions from the audience. If you guys have anything else, this is your last chance. I will just throw one out there that I've seen thrown around on Facebook, and I don't know if this is true or just one of those things that got started in the rumor mill, but there's talk about whether you should use ibuprofen versus acetaminophen or something else to treat your fever if one has more of a, you know, worse reaction than the other. Do you know anything about that?
Yes, there's not. I don't think, I haven't found anything that has any proof or any of the mechanism, like we just saw that guy explaining the mechanism or of why it would be that way. But anecdotally, that has been repeated over and over and over by lots of doctors that you should take ibuprofen. I mean, you should take acetaminophen, Tylenol, rather than any of the anti-inflammatories. So that's not just ibuprofen, that would be any of the anti-inflammatories. So naproxen and naproxen and what am I trying to think of? I can't think of any of the names right now. But, you know, there's 1,000 over the counters of those Motrin, things like that. Yeah,
leave anything that says anti-inflammatory ibuprofen probably. It probably just doesn't hurt to stay away from it if it's leaning that way.
Right. Yeah. But I haven't seen the cellular level explanation of why that is.
Okay. I think that's all we've got. So again, thank you so much for being on. I think this really helps clarify a lot of things for our folks, and I'll just reiterate what everyone's already heard. You know, wash your hands, don't touch your face, stay away from crowds, stand 6 feet away from people. You said, you know, gloves probably.
Yeah, don't buy into the people that are saying this isn't really scary. It's scary.
Yeah.
And as long as we're all behaving like we are, we have time to learn things that'll save us from it. But as soon as everybody just gives up and throws in the towel and goes outside, then all of us are in trouble collectively.
Yeah, and I think it's worth noting, you mentioned that people were stealing your hand sanitizer, and I've heard this from other offices, and we had a scare at the chamber even. We thought somebody took ours. It turned out it was just in someone's office. But
somebody put it away so nobody would steal it.
Somebody used it and forgot to put it back. But I will just remind everybody, you know, I don't think anyone in this group would do it, but you know, the idea is that we're all staying healthy, and if you take something away from other people that will keep them healthy, then guess what? You're going to end up getting, you know, being unhealthy because of that, because they're going to give it to you. So
collectively make sure everyone's got hand sanitizer and toilet paper. For God's sake.
Yeah. It doesn't help any of us if one of us is without and we have a hoard, you know, stockpile of it. So yeah, thank you guys for listening. And if you have any additional questions, you can send them to me through the page. I'll get the PowerPoint from Kelly and post it in our group. The Centex Planeteers does have a group on Facebook that's very interactive, and that's kind of where we share ideas, ask questions. And then if you are not already on our email list and you would like to be, just shoot me a message through the page or on the group so I can add you to that. And once we start having events again, you'll get our notices that way. We're also on Meetup, and yeah, if you don't already like our Facebook page, please do. So thank you so much, Kelly. Collective applause from the whole group. Everybody's saying thank you so much, and they love the info.
Thank you.
It's good to see you.
I'll get you the PowerPoint.
Okay, thanks. Bye-bye.